that 10 to 20 days of antibiotics is effective, that chronic Lyme disease does not exist, and that the treatment of chronic Lyme disease is not only not effective, but there is no evidence for any continued persistent infection. This is what the guidelines state. Now, like we said in the beginning, it's important to know the pathology and the biology of the organism to know that this isn't a simple bacteria. Yes, it is similar in its outlook, a spirochete, like syphilis. It is not as easily treated as syphilis. It is similar in that if you let syphilis go untreated, which was done in this country to look at the effects of syphilis going untreated. And this was the Tuskegee experiments that were done, that they just didn't give black men, black people, treatment. And they looked at the effects. And the effects were neurological problems, arthritic problems, heart block, and skin conditions. And psychiatric. Which, does it sound all familiar? Okay. So the biology of Borrelia is that small numbers of organisms secrete huge amounts of glycoprotein, lipids, and DNAs. These cause a very high immune response in the body. It causes people, even though small numbers of bacteria are around, people have a high response rate. It can shift in its morphology, in how it looks, from a spiral or spirochete form, which has a cell wall, which is treated with one type of antibiotic or anti-herbal, or an L form, which is a non-cell wall form, which is then treated by a different antimicrobial, or a cystic form, which tends to like to go to places that no one can find them. And that's in a small ball-like form, and it needs to be treated by a different antimicrobial. So when we go back to the tuberculosis kind of idea of a metaphor, having multiple drugs treat a single organism, again, is not new. It's pretty old. And it may be a good idea in the treatment of a disease that seems to be endemic, prevalent, and causing a lot of suffering. It also can survive within cells. It protects itself by means of disseminating within the cells, and it produces a film that reduces the penetration with antibiotics, and it's called a biofilm. It also, its life cycle is that it tends to grow and then not grow. Antibiotics and antimicrobials tend to affect growing organisms. They tend not to do anything to organisms that don't grow because they get it at an early embryonic stage. It's kind of like if you have a bird that's flying, what do the eagles do? They go after the eggs. They go after the newborns. So it's similar. New growth, continuous growth is easier to kill. So the deer mouse. Does anyone know what the deer mouse has? Yes, do anyone know why it's important for you? Yeah, so what's interesting about the deer mouse is that that's actually how we were told that it needs 36 hours to 48 hours of engorgement for treatment. It's based on an animal model. It's based on the deer mouse. And in fact, this is where the recommendation comes from. This is it. 10 mice. They looked at the attachment, and they said, okay, after 24 hours, when they biopsied the mice, only 0 out of 8, so none of them were infected. When they looked at 48 hours, it's 1 out of 9. So after 72 hours, they noticed 2 out of 8, but after 96 hours, it was noted that 8 out of 10, so they extrapolated back and they said, well, we'll give you 2 days. This is where your treatment was developed. It has not changed since this. This came out in 1995. So again, this is information. Clinical evidence for rapid transmission of Lyme disease following a tick bite was thought to require 36 to 48 hours. These results were based on less than 12 hours and one person that was less than 4 hours. In European study with 231 culture-confirmed cases involving patients with erythema migrans, so now your specific diagnosis for Lyme disease, 18% of them recalled a tick bite less than 24 hours. This underscores the possibility of early spirochetal transmission in some patients. This is 1996. So 10 years before the guidelines came out. And this is a case of disseminated Lyme disease in someone who reported a tick bite infection that was less than 6 hours. So what are the problems with animal models? One, typically you don't want to extrapolate animal models to humans. We don't have hair. That makes us different. I mean, we do, but we don't have fur all over our body. So it makes us different. We do have hair. That's right. Some people don't, and I don't know. I want to, because I'm seeing these stares by men that have less hair than me, and so I want to retract that statement. Can we? Okay. Laboratory strains that were done for this test are not found in the wild. These were laboratory strains of Borrelia. There were no co-infections with this bite, which we all believe that co-infections actually make infectivity higher. And other problems such as host immunity and the fact that there was uniform tick removal techniques, which aren't the case with humans. This is an unusual way to make a recommendation. So what do you do if you get a tick bite? Well, according to the IDSA gave you that guideline. According to the ILADS, which is what I follow, basically if you're bit by a tick and it appears that it's been on you for, I would say, greater than 4 hours, greater than 6 hours, it shows any sign of engorgement, any sign of a rash that's underneath the tick, then our recommendation would be to treat at least with one medication, and some would even recommend treating with 2, just based on the life cycle possibilities. So this is the IDSA guidelines for chronic Lyme disease. There is no convincing biological evidence for the existence of symptomatic chronic Lyme infection. Patients after receiving recommended treatment regimens for Lyme disease, antibiotic therapy has not proven to be useful and is not recommended for patients with chronic subjective symptoms after recommended treatment regimens for Lyme disease. Therapeutic modalities are not recommended because of lack of biological plausibility, lack of efficacy, absence of supporting data, or the potential for the harm to the patient. The following are not recommended treatment of patients with manifestations of Lyme disease. And essentially, this is a list of everything that could be helpful, including specific nutritional supplements and others. And again, this is just, I'm presenting this to you because in my practice and in my clinical judgment and looking at the evidence that is out there, the evidence that is out there does not support this guideline. And we really believe that the guideline has to be changed. And how it has to be changed is to have people that make up the guidelines be proponents of the IDSA, but also proponents of ILADS criteria, and also patients and people that make up who you're treating. But there is always prayer. The problem prayer doesn't always work. And in fact, in this study, with people undergoing bypass surgery at 6 different hospitals, the fact that patients were being prayed upon, they actually did worse. So I'm just making that as a point. So the current guidelines, how is the population affected? Again, what is the evidence? What is the risk-benefit ratio of treatment versus no treatment, of treatment for 3 weeks, 4 weeks versus 3 months, 6 months, a year? What is the clinical judgment? Is that valued? What is the value of the patient? What is your preference? And are we offering compassionate care? The criticism of the IDSA guidelines have begun, and this is actually an excellent article. It overviews the quality and strength of evidence of the Infectious Disease Society practice guidelines. This was reported in November 15th, 2010, and this is Infectious Disease Society of America and Clinical Infectious Diseases. This was Lee. He did another analysis of the overall level of evidence behind the IDSA guidelines, and what they found was only 14 to 16% of the thousands of IDSA guideline recommendations were supported by only one or 2 properly designed trials. Again, unheard of in current practice. As an ER physician, if I said to you, hey, you know what? I'm going to give you this drug, but only 14% of it is approved by studies. What do you think? Yes? You're going to go for it? Probably not, unless I would inform you. But this is what came up. This is actually even a better review. This is Allison DeLong. She's a biostatistician from Brown University, which I think is an Ivy League university. This is Contemporary Clinical Trials. She reviews 100 articles out of the IDSA guidelines. Only 4 articles were used to base the current guidelines against treatment. Only 4. Only 4. Out of the 100, only 4 were basis of the current guidelines. 2 out of the 4 were actually found statistically beneficial. In other words, 2 out of the 4 actually found benefit in reducing fatigue, which was not reported, which, if you take a history on anyone with Lyme disease, fatigue tends to be almost the #1 overall complaint. There could be differences in joint pain, there could be differences in headache or no headache, belly pain, heart problems, but overall, fatigue is one of the overall surmounting condition that people complain about.